Good day. I'm Anna Nolte. We're still busy in the Obstetric Emergency series, part 1. And today we're going to do lesson 2, which is about the delivery of the second twin. Now, um, now, when we're talking about the delivery of the second twin, and it's specifically the second twin that's usually associated with the emergency part of delivering a multiple pregnancy. You again might be wondering, like in the bridge presentation where we said that in most cases, multiple pregnancies are being booked for cesarean section. So why on earth would it be necessary for you to deliver a second twin or a multiple pregnancy? Now, emergency means it happens without you expecting it. So it's something that happens without you expecting it. And it might be, for example, just an example, where a patient has been booked for a cesarean section with a twin pregnancy, and then suddenly her membranes rupture. She's almost fully dilated. She arrives in your labor ward. The doctor is not immediately available, and you have to deliver the twins. So how are you going to do that? And again, like we've said with the previous emergencies, it's not something that you can practice. So you have to know that you have the knowledge, and then obviously, as we've said with all the other uh, emergencies, you have to have drills in your wards where you practice these things in simulation over and over again. Now, first of all, very important is the two types of twins. We get a monozygotic twin and we get a dizygotic twin. Now, what happens with the monozygotic twin is we have one sperm and one ovum cell. The sperm fertilizes the ovum, and this single ovum cell splits into two cells. And we will talk about the splitting of these two cells just now, because that, to a large extent, determines many of the abnormalities which we experience when we are doing this emergency twin delivery. Or we have a dizygotic twins where we have two ovums that's been fertilized by two separate sperms, and each one of these develop on their own. Now, in this case, usually each and every twin, every single fetus has its own placenta. They have their own amnion and chorion sacs, and they have their own liquor. So they are being two individuals developing totally on their own. But in the case of the monozygotic twins, we get different alternatives, different things that might be happening with the monozygotic twins, depending on at what stage does this single ovum cell divides into two different individuals. We can get that this early embryo splits before even implantation in the womb. So we got one ovum fertilized by one sperm, and before it lands in the womb, it has already divided into two separate cells, and this almost acts like a dizygotic twin. Each of them have their own placentas. Each of them have their own inner sacs, liquor, etc., and they develop all on their own. If this early embryo implants in the womb and then splits, we find that the two of them share a placenta, but they have two separate inner sacs. They have their own membranes, and they have their own bags of liquor, if I can call it like that. Excuse me. Or other alternative is that this embryo implants in the womb and then splits later. So here we get that find that we also have one placenta, like in this case, but we have only one inner sac. We have one total bag of membranes, if I can call it like that, and they share their bag of membranes. And this is usually in one of these two cases that we experience the problems. Now, another aspect that determines the emergency aspect or the problems that we might experience during the labor of the twins is the different presentations of the twins. We get that the twins can be lying in a combination of different presentations, which has a definite influence on the delivery of the fetuses. For example, we might find that both of them are in vertex presentations, or we might find that one is in a vertex and one is in a breech presentation, or we find two breech presentations, and here you can see the percentages of how often these happens. The vertex are the most common. Or we can have a vertex in a transverse, or a breech in a transverse, or two transverse presentations. Now, obviously, in the case of a vertex presentation, the chances of a normal delivery is the biggest. We might experience some problems with the vertex and the breech and the breech and the breech, but in these cases here at the bottom where one of the twins are in a transverse position, it's always a kind of a contraindication for a vaginal delivery, because obviously this twin can't be delivered in a transverse position. Now, what are the complications that's being associated with twins, and what are we supposed to look out for when we are dealing with these emergencies? Now, first of all, during pregnancy, there's a higher incidence of miscarriage and congenital abnormalities. The severity of the pregnancy symptoms are more, like, for example, the normal nausea and vomiting, the edema, the varicose veins, etc. All those smaller pregnancy symptoms are more severe in the case of multiple pregnancy. And also, there's the incidence of anemia is much bigger in the case of multiple pregnancies. Because the uterus has to stretch so much, we get a higher incidence of preterm births and other complications during pregnancy. For example, preeclampsia is also more common in the case of multiple pregnancies. And then the problems that's been associated with monozycosity, as I've said, is the fact that the two fetuses share a placenta is one of the biggest problems, because if they also obviously share a kind of a circulation system in the placenta. So if one of the first baby has been born and the cord is not being clamped immediately, the placenta literally bleeds into the cord of the firstborn twin, and that might cause a problem. The fact that they have only one bag of membranes is also a big problem, because they can get intertwined with each other, and we can easily get the lock twins that we will see, that I will talk about just now. There's a higher incidence of intrauterine growth retardation and discordant growth, and this also is more in the case of the monozygotic twins than in the case of the dizygotic twins. Then, as I've shown you, the different combination of presentations and positions, in the case of multiple pregnancy, we also have a higher incidence of malpresentations and positions. And then, because the uterus is being stretched so much during pregnancy, we also have a higher incidence of postpartum hemorrhage after the birth of the babies, for two reasons. The one is, as I've said, that the uterus has stretched so much, so it's difficult for the uterus to really contract again. And the other one is the placental area is so big, so it's difficult again for the uterus to contract in that area and really prevents postpartum hemorrhage. Then the intrapartum complications, those complications that happen specifically during the labor, is the higher incidence of abnormal lies and abnormal presentations, as we've said. Then there's a higher incidence of the prolapse of the cord as well, because depending on in what presentation and position the first twin is, and because the uterus is so big, that the moment when the membranes rupture, the cord can very easily just swim out with the light cord, and we get, as I'm saying, the prolapse of the cord is quite a big possible complication. Intrapartum hemorrhage, namely antepartum hemorrhage or placenta previa, much more often happens. Specifically a placenta previa, again, because the placenta is so big, a part of it can easily stretch into the lower segment and cause placenta previa. Then complicated delivery, specifically also because of the different abnormal presentations and positions. And then we get a condition that we call lock twins, and that's what you can see in these graphical presentations here, is if the first fetus, and this is specifically more so in the case of monozygotic twins, which shares a bag of membranes, is the first twin is being born as a breech, but then its head locks with the head of the second twin, which is in a vertex presentation. Or we can get, like in this case, where the first twin is a vertex presentation, but then the limbs get so entangled here in the uterus that we also get what we call a lock twins. So the first twin can be born partially, but then the rest of the twin can't be born. Then we also get a condition that we call twin-to-twin transfusion syndrome, and that is where the two twins share a placenta. And what can happen is during labor is that the one literally, the one fetus bleeds into the other. The cord is, for example, not been clamped immediately, and then the first baby's been born, and the blood of the placenta drains into the cord of the first baby, and that causes this, what we call twin-to-twin transfusion. Now, like in the breech presentation that we've said earlier, how we manage the labor, and specifically the second stage of labor where the emergency happens, depends to a very large extent on how we manage the first stage of labor. Now, before labor, it's very important that the presentation of the first baby should be diagnosed, so that if it's not the vertex presentation, a cesarean section should be done immediately, and it's indicated. But as I've said now, also in an emergency situation, the patient might be fully dilated and there's not really a time for cesarean section. The doctor might not be immediately available. So that will prevent, to a very large extent, our emergency if it can be diagnosed before the time. Now, then also very important how we manage the first stage of labor. Now, there's not a big difference between managing of a singleton's first stage of labor and that of a multiple pregnancy. We do it as normal. We do all the observations are as important as in the case of a normal pregnancy and a normal delivery. We do the observations, we observe for complications, we identify the problems, and we deal with it as we are identifying it, referring it to a doctor or whatever is necessary. What is extremely important in the management of the first stage of labor is to continuously do a CTG of both the fetal hearts. Now, we usually say that there should be a difference of between 15 and 20 beats per minute between the fetal hearts to make sure that we have two separate fetal hearts. But the most reliable way of monitoring the fetuses is to do continuous monitoring of both fetal hearts. We can either do it, you get very smart CTG machines that you can monitor both fetuses at the same time on one machine, or if you are in a position that you don't have such a smart CTG, you can use two CTG machines, and you listen to the fetal heart, you connect the the tochographs to where you hear the different fetal hearts and you monitor the two fetal hearts simultaneously. This is extremely important so that if there is fetal distress, because it might happen because of all these problems that we've said with the placentas just now and the cross transfusion syndrome, etc., that the one fetus might be in a very good condition and the other fetus is not in a good condition. There might be fetal compromise in the one fetus and a good, normal, reactive fetal heart in the other one. And that is why it is so important to monitor the two fetal heart rates continuously. It's good to do an epidural, give the patients an epidural anesthesia, so that if there is any other, if there's a problem and we need some or other interference, that the patient already has an epidural. And then, like I've said in the breech presentation, always when there's some or other complication or when we expect some complications, it's a very good idea to always put up an IV infusion for a patient during labor. And as we've said already, that these patients are having a very high risk of postpartum hemorrhage during labor or during the postpartum period. This is already one of the reasons why we need an infusion, IV infusion. And you will see also now in the second stage of labor and the management of the second stage of labor, it might also be necessary to augment labor. And then we already have an IV infusion on and running. Now, what do we do during the second stage of labor? Because as I've said, this is now where the emergency comes in. How do we manage the delivery of these babies? Now, first of all, if the presentation is normal, and this counts for both vertex as well as breech, we manage it as we would have done with a normal breech delivery or with a normal vertex delivery. We have talked about how we do a normal breech delivery, and you all know how to deal with a normal vertex delivery. So we deliver the first twin like in a normal way. Again, very important to continuously monitor both the fetal hearts. Now here it might become a little bit difficult with the CTG as the one fetus moves down into the pelvis and the other one stays higher, but it's still very important to try and as much as possible to continuously monitor both fetal hearts. Very important to note the time of the birth of the baby, and we will come to that just now when we do the delivery of the second twin as well. We obviously are not going to give oxytocin after the delivery of the baby because that will cause contraction of the uterus, and there's still one fetus in the uterus that needs to be delivered. So it's very important not to give oxytocin. Then we immediately clamp the cord. This is very important because of the possibility, as I've said, that the one fetus can bleed through the placenta into the other fetus. So here we don't have any delayed cord clamping. We clamp the cord immediately. And then obviously it's very important, obviously not to deliver the placenta because we again don't know whether there's only one placenta, whether the two fetuses share the placenta, or whether there are two different and separate placentas. Then the second stage of the second baby. Now this is where it becomes very important because the first baby can be born normally. But as I've said previously, the second baby, there might be all kinds of complications, of which one of the biggest is that they share a placenta. This placenta might go loose. The first baby might have bled. The placenta might have bled into the first baby a little bit, etc. So this baby is very important. Now, in many of publications and over the news, you might have heard that there is that in the case of a twin pregnancy, the one baby has been born and days later the second baby has been born. It's very possible that it can happen, and specifically in the case of where the babies have two separate placentas and two separate amniotic and chorionic sacs, etc., that might be possible. But because we don't know what is going on inside the uterus, it's always better to get the second baby out as soon as possible. So after the first baby has been born, we immediately try to determine the lie and the presentation and position of the second baby. So we do an abdominal and a vaginal examination immediately after the birth of this first baby to determine this. Then we still continuously, if at all possible, do a CTG of the fetal heart of this aftercoming baby, because this baby is now a very high risk baby and we need to determine whether he's in a good condition or not. If the lie is not longitudinal, we might determine what the lie is, and if the lie is not longitudinal, like we've said previously that the baby is in a transverse position, we can do an external or an internal cephalic version, like I've shown you in the case of a breech presentation, to turn this transverse baby into preferably a vertex presentation, or we can also do it into a breech presentation. So we do a PV to confirm the presentation. Then if the membranes haven't been ruptured, we rupture the membranes. Now here it's very important that we don't rupture the membranes if the head is still high. The head should be low. Otherwise, we might sit with a big problem of a cord prolapse. So we have to wait till the second baby is also engaged into the pelvis before we rupture the membranes to prevent this prolapse of the cord. Now, as I've said, the second twin is usually the high risk. So we're saying that the birth of the second twin should ideally be completed within 45 minutes after the birth of the first baby. Because, as we've said, there's a high risk that the placenta might get loose. Specifically because in the case of a multiple pregnancy, the uterus has been stretched a lot. Now the first baby is being born and the uterus starts contracting, and that might cause the second placenta to separate and start separating. Now, our big thing here is to, as I've said, to continuously monitor the fetus with a CTG to look for signs of fetal compromise. Signs of fetal compromise will tell us that the placenta has gone loose, or that there's been a transfusion between the twins, etc. If there's no sign of fetal compromise, we can allow the second stage of labor to be a little bit longer. So here, the condition of the fetus will be of utmost importance for us to determine how we're going to deal with the second stage of labor. And if there are signs of compromise, then obviously the birth must be expedited in the sense of a vacuum delivery or a forceps delivery, etc. Now, what do we do further on? We check that the IV is running, and if we don't have an IV up before this, it's now time to really put up an IV, because we might need it for augmentation. If the contractions, and sometimes we do get that after the birth of the first baby, the contractions disappear because again of the uterus being so big, and now it's been much smaller, and it almost kind of does not know what to do with this smaller size. So we might need to augment labor with oxytocin, and therefore we need an IV infusion. And as we've also said, there's a very high incidence of the possibility of postpartum hemorrhage. So we augment the labor if necessary, and then we manage the delivery, if it's a vertex, like a vertex or a breech delivery, and then we can now give syntocin to the baby, to the mother after the birth of the baby, after we've made sure that there's not a third baby as well. And then very important, as I've said many times now, is the possibility of a postpartum hemorrhage for which we should observe the patient. And that brings us to the end of the multiple pregnancy and the management of the multiple pregnancy, and specifically the management of the second stage of the second twin. And I hope again that you've learned something, and I can't emphasize it enough that you have to practice this at the regular stage. Renew your knowledge about this at the regular stage so that when it does happen to you, that you know how to deal with it.